she's been evaluated for rectal pregnancy loss. All investigations, that is her thyroid, her APLA, her TSH, all that was normal. The ultrasound is also normal. So she's in for a hysteroscopy before planning her next pregnancy.
Okay, thank you. Sorry?
History of tuberculosis.
Yeah, there is a history, of course. Raina Rajesh tells me of tuberculosis and being treated. She was treated, again, this is a controversial topic which hopefully we'll discuss in the round table this evening, as well as tomorrow we have a very nice detailed lecture on it, on tuberculosis in the endometrium. So she has been treated on an endometrial biopsy which showed TB-PCR positive. Thereafter, a repeat biopsy was done and it was negative. So that's the other part of the history. What we are doing again is, I'm going to show you slowly. I'm going to again do a vaginoscopic method in this patient, this lady, before we then apply it for the participants. What we do here is, again, to go to the basics, is we've emptied the bladder, we've done a pelvic examination. Again, it is anteverted, acutely anteverted, so my hand position is going to be down. That is, I will be like this. Okay, can you see my hand? My telescope is going to be facing like this. We're going to talk about it when we show you it, give it to you in your hands. This is a 30-degree chipped lens. So what I'm going to be seeing when if I go in directly is going to be the posterior wall. Hence, my hand is going to be like this in an anteverted uterus. Now, what we're using here is again a high definition. What I generally use, my camera that I use is a Karl Storz high definition camera with a high definition monitor and the xenon light source. We're using different cameras here because we show you the range of it, but Karl Storz is what I use. The telescope that we're using in all the surgeries here is Karl Storz, of course, which is, I said, one of the best telescopes, and a chipped lens, of course, which helps us to see much more. I'm going to begin this. We're going to let the fluid on here run through the distal part. Once it runs through the distal part, I will go into the vagina slowly and let the vagina distend. Let it take its time. Don't be in a hurry. If you're in a hurry, you're not going to see anything, because it takes time to distend and for anything to happen. So we let it distend slowly, let the fluid pressure come. Once it's distended, we look for if you don't find the cervix straight ahead, you look for the posterior vault, and once you see that, you should be able to eventually trace that and find the cervix.
Approximately how much saline is needed to inflate the vagina?
Ma'am, it will depend on obviously the space of the vagina, but you don't need more than maybe about 10-15 constant pressure. You would be able to see it. You see, that's the cervical mucosa here. So maybe 20-35 cc of continuous flow will lead you to see. That's the cervix. It's like an open sort of mouth. I will just follow the fluid slowly. It's like walking into a room. I've already done a pelvic examination, and I know my uterus is anteverted, so my hand position is going to be, if they show the external camera to you, I'm going to go way down. Can I have the table raised, please? I don't like being uncomfortable when I'm doing the surgery, so I will make myself comfortable either by sitting down, like one of the participants here wanted to, or by raising the table. It's very gentle motion. I'm letting it distend, and then I'm going to go inside slowly. Again, like I said, slowly we're going to do that. Go in, follow it. That's it. Thank you. Going into the curves of the cervical canal till we actually reach the cervical canal, and that's the uterine cavity. We're now at the junction that we follow the lateral wall. We go up here, it goes to the ostia, we go back, posterior wall, follow the lateral wall, it should reach the ostia, back here.
Just show them the lateral wall again so they can see the length of it. They didn't see, in the other case.
Okay, that's the lateral wall. Okay, I'm following the left lateral wall of the patient, and it should reach my ostia here. There. That's the ostia there. I come back out to the left lateral wall. I go back, turn my light cable at 90 degrees anteriorly, I see the posterior wall. Then I go to the other side, I turn my light cable and I see the other ostia there. It's a little bit inside a crevice, but that's fine. It's not too.
So that the difference in the size of the ostia.
Okay, that's the ostia here, which is much larger, if you can see. I'm going to go to the other ostia and you see it's more pinpoint. Okay, so mild adhesions at the ostial level, which I'm going to dilate. Otherwise, if I see the anterior wall, that's it. Nothing home to write about much. Slight adhesions on the anterior, on the fundus, but like I said, more than adequate cavity for a conception. I'm going to dilate both the ostias. My scissor is in place, so I'm just going to go there with my scissor slowly and give it a bit of a snip here. Again, these scissors, somebody was asking me what is the magnification. The scissor that I am using here is again, of course, a Karl Storz 5 French scissor. 5 French is 1.6 millimeters. So you normally what we do is we always compare it to any food stuff when we're talking about, or of course any organ that we know the size of.
Common denominator.
Common denominator. So that's how we would compare this. So this is just a 5 French scissor, which is 1.67 millimeters. There I'm going to make a bit of a snip here at the fundus.
Can you see those bands across now when he cuts it? You saw that in the others as well. You can recognize.
I'm doing it more on the right side because the right ostia was a little more deep seated. There you go. Ostia is opened up. You see the lateral wall reaching the ostia, so there's nothing there that we need to do. Remember I told you about a lateral wall metroplasty? So if your lateral walls normally reach and the cavity size you can see is more than adequate here, I don't need to do anything. If the central cavity, somebody was asking me, even if the lateral walls reach at times the ostia, in a T-shaped uterus at the distal part, you will need to maneuver them and it will be in a crevice. But even if they reach and if the central portion of the cavity is smaller than what you would think clinically, with repeated hysteroscopies you should be able to tell, then you would do a lateral metroplasty and open up. How much would you do? I would use of course a scissor, but if you do it with a resectoscope, you can actually, the Collins knife is what you use, and that is about 2 millimeters. You could make cuts of 2 millimeters, and you know the thickness of the wall, lateral walls on an ultrasound. So that will be your guide as to how deep you can go again. But otherwise, in this particular lady, this would be the end point of my surgery. Let me show you the endometrium. You can see hemorrhages here, but I'm going to show you the opening of the endometrial glands now. You can see the white dots here. Yeah. So these white dots are the openings of the endometrial glands, and they're smaller than those other larger ones that we can see, which I hopefully will show you. So she should be in proliferative stage still. There you can see the white dots. So you go closer when you've seen all the walls, you go closer, you see the openings of the glands, you see the endometrial stage, and then you come out.
Can you just for a minute show them with an instrument how you open up the os sometimes? You know, you put it in there, maneuver.
You're dilating the ostia?
Yeah, just
okay.
that.
So all you do is, your instrument is your scissor which you're going in, it's there. I guide it there, and all I do is I open my scissor there. Can you see my open scissor there? Yeah, there, closed and open. That's all I'm going to do, and that will open up the ostia there.
Is the patchy endometrium could be because of endometriosis, or this is normal?
This is normal. You could have a bit of a chronic inflammation in this because of that, but this is not something to write home about.
Sometimes we see little ecchymosis around the ostias.
Yes.
Could
That again, shaggy endometrium and ecchymosis could be due to chronic inflammation, some inflammatory disease that she's had. That's the reason why it could be there. In fact, Dr. Priya, I don't know if she's there. Dr. Priya hasn't come. I'm sure I'll get to know when she comes, but she should be able to tell you more on that because she is the IVF specialist and does a lot of hysteroscopic work. So she will tell you a little bit more on that. So we're coming out, we'll have a look at the cervical canal, and that should be end of this hysteroscopy.
Sir, why did we cut it fundal area with, in spite of good uterine cavity? We had enough space in this patient.
Good question. There were some gathers on the uterine fundus there. You could have doc gotten away without doing anything also. The right ostia, if you saw, was in a bit more of a crevice more than the left ostia. So in my clinical I just sort of did a few snips on the fundus, but you could leave it also. I don't think there should be a problem. Any other question that you'd like to ask? We are happy to answer. So this lady, I think, is now, I don't see any reason in the cavity for recurrent abortions. She'd already had an endometrial biopsy and now a negative PCR test. So we're going to give her hopefully a good report as far as the hysteroscopy goes. And I'm hoping she'll come back with some good news. And maybe in her next pregnancy they could do a cerclage for her.
Dr. Rahul?
Yes?
This being a case of recurrent pregnancy loss, I think the removal of adhesions was necessary in this case.
Well, the adhesions, could I know who I'm talking to?
Dr. Seema.
Dr. Seema, the adhesions in this particular case were very minimal. But yeah, because of that history also, I did, in my judgment, I thought I would agree with you, maybe removing them was a good idea, which is why I did them.
Alright. And I have one more question.
Yeah.
What I noticed, the color tone of the endometrium in this case was different from the previous two cases. Is it because a different phase of the cycle?
Yes, absolutely. Absolutely. Most of them we've tried to keep in the post-menstrual phase.
Right.
But being a workshop, we couldn't have all of them. So you will have some of them which will be even thicker endometrium and different. So probably because of that.
Alright. Thank you.
Hold this in your left hand. Fluid on. इसको पकड़ ले अपने हाथ में. इसको हाँ. Just hold it from here. Okay. Put the fluid on. Now this in your left hand. पानी दो. Go into the cervix. Cervix में अंदर डालो cervix में. That's it. Go in cervix. Yeah, that's it. Speculum निकाल लो. सीधा anteverted uterus है ना, ये वाला. हाँ, हाथ में पकड़. ऐसे करो. इसको छोड़ दो, ऊपर वाले को ऐसे रखेंगे. ये मेरे को दे दो ऊपर वाला. हाँ, इसको ऐसे
You
करो.
were just announced.
Yeah.
Hello?
Yeah.
You were just announced that the next case is in 15 minutes.
Okay. We will take up the next case in 15 minutes, please. So, if there are any questions, we can take them. Otherwise, we'll leave you to the auditorium downstairs. And if anybody is watching us on the webcast, we'll be back with you in another 15 minutes.